All right, welcome to the CoROM Conversations. This is for September 2025. We are going to be continuing on with our sea circulation problems in sepsis. My name is Aebhric OKelly. I'm a critical care paramedic, and I'm joined with Bill Vasios. Bill?
Hello, I'm a PA, a doctoral student, and a simulation fellow at the time.
Cool. So what we're doing is we're walking through the CPGs, and I've broken it down into kind of the March algorithm. And what I've done is I've just bunched each of these CPGs into the March pause L. And each one of these has a link. So if you want this spreadsheet with all of the field guide or all of the CPGs, you can click this or you can scan this. And I'll leave this up for 5 seconds or so. You scan this, this goes to my personal Dropbox that has the CPG spreadsheet. So you can access the CPGs, find the ones you like, download them, or better yet, go to the JTS website where the source is. So we're going to go through the March pause or the CABC algorithm. On the left is the CoROM. Our college has a CABC DEFGH algorithm because H you end with Hitman when forces you to go into prolonged field care. On the right is our TCCC, which March pause L, and then we just hope you go into prolonged care. But everything we talk about with everything needs to end in prolonged care if we can. So C circulation. We've gone through M, A, and R. We're now at C circulation, and we're talking about sepsis, which is part of C circulation. And we're going to use this CPG. Bill?
Yeah, actually, I go back to the CPG one. So if you haven't read this one, it's a good read, but it's probably a deeper read than most of the other CPGs that we've covered to this point, only because it does a really good job of trying to translate hospital medicine to remote or prolonged field care environments. It's a different perspective. You have to know how to do it right in a hospital to understand how to adapt it for whatever environment that you find yourself in. And we all find ourselves in those remote environments where we don't have all of the lab capabilities, all of the personnel, all of the equipment to figure out what's really going on. And so this is one of those systems and cases where you really need to develop a clinical acumen to predicting and anticipating not only what is the most likely thing that's going to happen with your patient, but what's the worst thing. And sepsis would definitely fall into that category of a really bad thing or the worst thing that could happen to your patient. So go ahead to the next one, Aebhric.
All right.
So understanding what sepsis is a big thing that I tend to talk about when I'm relating to this. And it's kind of a spectrum from bad infection to crossing over into sepsis, to then to crossing over into septic shock. And I think the CPG does a pretty good job of just outlining that. So sepsis is that life-threatening organ dysfunction that's caused by a dysregulated host response to a severe or significant infection. And then when they cross over into septic shock, now you're talking about organ failure and other management issues. You go from a complicated condition of sepsis to a complex situation of septic shock where you're managing multiple organ systems to try and get them all to work. And your goal is in anything is to recognize when this is taking place, when it's starting, where it could go, and kind of heading it off at the past. And that means recognizing that there is a source for your infection and having the differential to figure out what it is so that you can respond appropriately. And then there's some generic antibiotics that you can start off with, but then you want to be able to, refine that into something that's more specific to what you're actually dealing with. And I can't emphasize this enough. The minute you think or realize that you have a really bad sick patient that's in the sepsis or septic shock range, you should have already been speaking with somebody that is not in your same condition, but can sympathize and empathize with what you're dealing with and help talk you through the management with whatever resources you have available. So I think that's something that you need to keep in mind and recognize early, and be professional enough to reach out and get some help, because I don't care how good you are, managing this by yourself is just a daunting task, and it's not one that you really have to do if you have the resources to call and ask a friend. So anything to add to that, Aebhric?
Yeah, so the big one for me is recognition for us knuckle draggers. So there's a lot of extra toys that Bill and all the people with the big brains have in hospital. It's brilliant, but those of us on the ground, we don't have it. So I think it's really important for us to really get a red flag in our head if we see someone who is starting to show signs of sepsis, and do your QSOFA, do your the news 2 score, and quickly, the faster you see this, the faster you get antibiotics on board. Is going to save a life. Sepsis still kills a lot of people in Western nations.
Absolutely. You want to go to the next one?
Yep.
So kind of starts with you having an idea of what's the most likely thing going on with your patient and what's the most dangerous thing. And so the minimum is to get a good history of what's going on and start documenting and trending vital signs. Now, the different early warning systems or anticipatory, like what's going to happen to your patient, those measures of the QSOFA, the SIRS, and the news. How many people in the chat here are familiar or comfortable or have used any of those early warning systems, the QSOFA? Any tendency towards one or the other? Like who's got something where it really helped them? Or the QSOFA? Okay. I like the QSOFA because it's quick. The next slide kind of covers what each of these are. There's some good literature on where it helps. I have an opinion, and I'll talk about it in the next slide. But you're going to need to start trending using your flow sheets or whatever method you have of monitoring your vital signs over time. And then as you have more capabilities, you can do some simple labs with a iStat, or labs. If you have a local clinic that you have available to, you can do your point of care labs, your urine dipsticks, or your rapid tests. Those are things that will kind of give you an idea, but that should confirm or deny things already on your differential. You shouldn't be doing those blind labs to just see what's going on, because one of the difficult things in medicine is to get an outlying lab that has nothing to do with what you're really dealing with, but it's a confounding factor that causes you to run down lanes that you may not need to, because you just did a lab thinking, all right, I'll see what I get. You should really do any test with the idea of how is this going to change what I do and treat the patient. That's an important thing. And then if you're in a malaria endemic area and you have a really sick patient, guess what? It's malaria until proven otherwise. And it's probably still malaria. Just because you don't see it on the thick and thin smears, that may be operator error when you're doing this. But, the diseases endemic to your area need to be on your radar for, one, how to identify them, how to prevent, well, let me back it up, how to prevent them in the first place, because that is the best treatment and diagnostic method, is to prevent the injury first. So you're making sure that your folks are taking their preventive medicines. But when they come in and say, oh no, I've taken everything, almost all of those patients have missed a dose or two of their antimalarials, but they don't admit it right away. They don't admit it till later on. The extra lab values, I am a fan of having information, but I'm very particular on whether it will change what I do. So if you're working in a hospital, there's backups and labs and people. So you can do a test, and you can wait for those results, and it will change, because you have a whole facility behind you to treat your patient. When you're in a remote area, you have a handful of antibiotics, a handful of diagnostic measures. And so what do you do with that information? So sometimes more information doesn't make your decision better. It just gives you more data points. And so have an idea of what you're going to do based on the most likely diagnosis that you're going to have. That's kind of how I would approach it. Does anybody have any comments or thoughts or questions on this H&P stuff? It's pretty basic, but any caveats or anything that would kind of help the rest of the group?
What would you say your list of simple labs is? I'm assuming lactate.
Well, so okay, lactate's a good information. Lactate's a good test, but can you still treat that patient without a lactate?
Yeah, we've got end-tidal.
Yeah. So if your iStat doesn't work and you can't get a lactate on it, or you can't get some of your simple labs, how are you gonna base your patient's response?
Yeah, I mean end-tidal, and just assuming based off of the rest of our vitals.
Your basic vitals. And so the three plates that I think that we all need to learn how to manage. One is maintaining a map, right? So you need a map greater than 65 so that you know that you're perfusing the vital organs. So you need volume. The second thing is, how do you know that the volume is sufficient? You're going to measure urine output. And so if they're making the appropriate amount of urine, then you know that they're perfused appropriately and their organs are functioning so that they're producing urine based on that map, right? The third thing is the other variable is how is your patient mentating? Are you able to communicate with them? Are they awake and alert? And are they confused? Are they alert and oriented? So if you can manage those three generic plates of, do they have, significant perfusion? Do they have validation with urinary output? And do they mentate well and think clearly? If you can do those, then the rest of these specific lab tests that you're doing are nice, but they're not needed. If you're in a truly remote area and you don't have the ability to do those labs, if you can manage those three things and base the treatment and interventions and responses off of those three plates, then you can still function, but just not as comfortably as you would if you had those extra information and data points. Does that make sense?
Sure. Yeah. I mean, I think my question is more, I feel quote unquote comfortable with having less information and making general guesses. And I feel less comfortable knowing more because it reaches a point of where my knowledge is met up with lack of knowledge. And so that's why I'm sort of asking, is there specific lab values that'll sort of, like you said, not just complicate your question, your treatment, but actually improve?
Yeah, I agree. I think the numbers are good for a well-staffed and equipped facility, because a lot of those go on numbers, and that's what those early warning systems are designed to do. It's like, which of our sick patients are going to become really sick? Which of our sick patients are going to die? And so can we intervene earlier to change that outcome? And that's why those early warning systems like the QSOFA, SIRS isn't part of the definition anymore of sepsis, but it's a really good way to monitor your patient. And then the news, it's an early warning system, the second version. So I think having those early warning algorithms, if you will, kind of helps predict in a facility. But if you're the only person, you're already prioritizing your treatment for what you're dealing with. So I think the generic list of labs that would make me feel comfortable are based on the geography and where I'm actually working at. But I would go with the standard vital signs that I would trend on a flow chart as the basis. And then anything above that is either helpful if it changes my treatment, and not helpful if it confuses me and I don't do anything based on the results. Yeah, that's kind of how I would say that. Any other questions though? Did I answer your question, Tange?
Yes, as in saying that the labs aren't really important. So let's say I go into like a rural clinic and they happen to have all these labs. What am I ignoring and what am I paying attention to?
Okay. Well, I think any lab that you get back that confirms what you think or will cause you to change your treatment, meaning, all right, do I need to continue to give antibiotics if I get a clean white count?
Right.
What does that mean? Does it make sense with the trend on your patient? If you've only been treating the patient with antibiotics for a day or so and you get a white count that's normal, do you stop? That's where sometimes those lab results can be confusing. Because you want to follow the treatment regimen. You want to go on how your patient's doing. I think the best example to this is pediatrics. I mean, pediatrics, The peds are able to compensate so well up until they can't. And so you have to develop that instinct and that intuition about how your patient's doing. And actually, I was just reading an article that talked about the QSOFA, the SIRS, and then some other early warning system out of Korea that isn't as refined in the elder population. The age factors, because you're basing it off of vital signs and some findings that are different in the elderly. And so how accurate are those early warning systems in somebody that doesn't have a baseline normal vital sign, so to say, otherwise healthy people that we're going to deal with in our environments. So I think every system has its benefits and drawbacks to it. I think you have to develop a comfort with it. And if you're used to using lab results to change how you treat your patient, then you become more comfortable. But if you're in a remote area all the time and you don't have access to those labs, well, then it's hard to become comfortable with something that you don't use frequently.
Right.
Yeah. That's a long way to say that I think you're on the right track as far as being comfortable with the labs that you can get, but being able to be comfortable when your iStat doesn't work. Aebhric, you were going to say something?
Oliver Wendell Holmes was right. It's all about patient history. So we should have that clinical acumen before we start thinking about labs, and the labs are only there to say, right, I was right, it was sepsis, and now I have science to back me up. But so as your casualty comes through your door, as you get on scene, there's clinical science that should put you down this pathway. And I guess I would like to see you more of aggressive approach on sepsis diagnosis, because we're missing them. So that QSOFA is awesome. Shock index, I don't know if we're going to talk about that. That's a great, really quick clinical clue that says, hey, whoa, oh, I might have a sepsis patient. Let's get some laboratory values that's going to prove me wrong, hopefully, or prove me right, and we go scoop and run.
All right. The next slide talks about the warning system, the QSOFA and the news. So the QSOFA is quick, right? It's a quick sepsis related organ failure assessment tool. It identifies patients with an increased risk of death, and it focuses on what is their systolic blood pressure, what is their mental status, what's their respiratory rate, and what's their GCS, right? And so anything greater to or equal to or greater to than a 2 suggests that patient has a greater risk of a poor outcome. I think with your experience and your gestalt, you can look at a patient that looks like crap and you can figure out what's going on, especially if that's somebody that was a coworker and you're familiar with how they are. That's going to make your assessment of their mental status more accurate. You can count respirations, you can look at them and see that they're breathing fast. Okay. If you can't tell how fast they're breathing, it's probably normal. So that's a good visual reference tool. You can take your blood pressures. You can also check peripheral pulses. Now, it doesn't relate to directly to a systolic blood pressure, but it can tell whether it's strong, weak, thready, consistent, abnormal. I mean, you can get a characteristic on doing a peripheral pulse and a central pulse. So this is a good quick thing that you can get with a gestalt by just walking up, talking to your patient and checking their pulse as you're looking at them. And then you can do the hard data by measuring the systolic, counting the respirations, and doing a GCS calculation for them. But the answer is in the acronym QUIC. It's a quick visual backed up with a little bit of statistics. So it's helpful to kind of say, all right, is this patient as sick as they look? If they look like shit, or if they look good and you get abnormal findings like this, there's an incongruity for what you're seeing into what you're measuring. And then that's something where your experience comes in. I think these numbers are good to learn, but it's a way to cheat the education and experience curve. If you see a lot of sick patients and you're dealing with them, you're going to just develop a sixth sense of who's going to crash and who's not. And it's kind of hard to transfer that experience without actual time. The coming up with these early warning systems is a way to kind of cheat that learning curve, if you will. And then the news is not quick. It's more in depth and it has more data points that you're looking at. And so how fast are they breathing? That's still a calculation. You're going to look at their score. What is their SATs? There's actually 2 different SAT scores. Somebody that has normal respirations without a chronic disease has the full normal range of oxygen saturation. But if you have somebody with COPD or emphysema, their saturation score is adjusted to 88 to 92% is kind of their semi-normal range, where then that's going to start affecting your score. So it's adjusted for somebody with a chronic condition, so you don't over-treat them. But you also realize that they can compensate less than, say, somebody with a normal respiratory system. And then you're just going all the way down, looking at, temperature, systolic blood pressure, heart rate, and then, just a generic, not a Glasgow coma scale, but an AVPU for their level of consciousness. So these are just different tools. And I would say that being familiar to the level of comfort with them will help you. And having a quick cheat sheet is another way to do this. So like anything else in our drug sheet, we should keep a drug quick cheat sheet for how to calculate all our stuff for the people that we're working with. I think we should have a quick reference for the QSOFA and the news to kind of give us an idea. Do the numbers back up what gut feeling that we're forming when we look at a patient? Do we see whether they're sick or not sick, stable or unstable? I think it's a way to kind of help solidify that experience curve of looking at and dealing with sick patients. Any thoughts, comments? Does anybody have a preference, the QSOFA over the news?
Can you substitute AVPU for GCS in QSOFA? So instead of anyone with a VPU gets a point in QSOFA, because it's obviously way easier to calculate than a GCS.
Yeah, no, I think if you're walking up to the person and you're like, you hear yelling like, "Hey, Aebhric," and he's got his eyes closed. If he opens his eyes and he looks right at you, well, then he's alert. But if he opens his eyes and he's looking for the voice that's calling to him, then he's responding to verbal. So his GCS is not 15, right? So I think that you can, on a broad scale, substitute AVPU for GCS. But you're going to base it off of your response, and you're going to do it quickly. Does that make sense? It's not as refined. You don't have a hard number, but you can say that if he's only responding to verbal and not alert, well, then he's altered.
Absolutely.
Yeah. And then you can look to see if he's visually injured, if that's why he's not able to, respond to his eyes or his motor responses. Right. So. No, it's a good question. It's a good comparison. I think you can swap them. And then when you go back later to buff your chart, which is putting all your numbers down after the fact, which generally happens in a chaotic situation, you can kind of go, all right, here's what it is. Here's AVPU or GCS. Good point though.
I think Sven had a question first.
Okay.
No, I just had a quick comment on the AC or AVPU. We use the news score on a daily basis, and we translated it to the GCS, which is basically 15 is 0 points and everything else gets 3 points. So basically what you said.
Okay, you go all the way to 3?
Yeah, so in the news 3 points, not the GCS 3 points. So basically 14 or less on the GCS gets 3 points.
Okay.
Mason?
Yeah, I was going to comment on that. I mean, I think that's kind of one of my pet peeves is when people use GCS for everything. It was originally developed for head trauma and assessing the severity of head trauma. And when you're actually looking at like a general mental status, I think AVPU is actually a lot clearer and more refined in the information it gives you, because it's not just a random number. I don't know how they got that number. I know with the AVPU exactly what it is. And unless you're expecting trauma with lateralizing symptoms, the GCS is really probably not as relevant, at least in my opinion, as AVPU or as simple.
Mm-hmm.
I'll add on. I agree with that, Doc. I do. So at the college, we use AVPU more than GCS because GCS scores can vary from people who are counting it. But the AVPU is great, but with the A, we break the A down into 4 additional levels of alert and oriented times 4. So if they're aware to person, place, time, and or event, within that level of A of AVPU. So I would say I would be careful enough with sepsis that if they have an ANO times 3, in other words, they don't know one of the person, place, time, or events, then boom, they have a 3 on the news score, or they have a yes on the QSOFA.
Yeah, absolutely agree with that. That makes a lot of sense.
Mm-hmm. So I think you bring up a good point, Mason, too. The GCS is designed for head injury, so that they're saying that there's the reason for a decrease in their response for eye, verbal, and motor is because of a head injury. Whereas in a septic patient, it's organ failure, not just the head injury. So are they so depleted of perfusion that they're not mentating properly? Are they not making urine? Are they, do they not have end organ function, or are they in dysfunction? So I think that I would definitely give an unresponsive score a 3 in the news. But if they only responded to pain or verbal, like verbal, I wouldn't go to 3 for verbal. I don't know. I think I would give them a point or 2, but I don't know if I would go right to 3 unless I looked at them and they just looked overly sick. You know what I mean? So there's that gray area for verbal. If they only respond to pain, then they're pretty deep, versus just the verbal of looking at you or being a little disoriented. So I think there's a spectrum there, but I don't know if it goes right to a 3. Granted, it's all in the bad column, so you're probably not wrong for assuming it's 3 and treating aggressively. But I think you can treat aggressively without just overemphasizing that score. Go ahead, Alfredo.
I just want to highlight the importance of temperature on a patient with sepsis. I know there's a lot of studies that come out in the recent years taking the hyperthermia away because there's some people don't change the temperature or even become hypothermic. But in fact, 9 times out of 10 the patient we see they're septic, the temperature tends to go high, and even touching them, we already know what's going on. We may call pattern recognition, but actually we're touching them and they're hot, and then probably is a bug going on. Regarding News 2 versus QSOFA, I personally believe QSOFA is quite generic, because imagine if you have a patient who is dehydrated, for instance, it will show as a QSOFA as positive because the blood pressure will be low, you're going to be confused, and respiratory rate will be high, and not specific for sepsis. News 2, of course, is not as specific as well, but will give us more information. Thank you.
Yeah, I think we can have polytrauma patients and they can be sick. So they have a stewing infection, and then they happen to get injured related to trauma. So that becomes an instant complex patient. So I think appropriate application of the QSOFA in a sick patient versus a traumatized patient, I think, is what they're looking at here. But I agree with you. It is very generic. It kind of matches with numbers, your gestalt feeling when you visually look at the patient. So, Mason.
I was going to add on a couple things to the temperature comment there, and maybe someone can tell me if this is evidence-based or not, but something I've found in my practice is that sometimes patients who don't have a measuring fever still feel warm when you touch them. And in my head, I've chalked it up to because they're vasodilated from sepsis. So even though their core temperature is not high, their peripheries are warmer than you'd expect, so they have more heat loss, and you can feel that when you touch them. I find that that's like a very sensitive indicator of someone who's sick, particularly older people. And then moreover, what you can do is you can, when they get really sick, they start getting cold from the feet up to the torso, and you can feel where the warmth goes down to on their leg as to how well they're doing. At first, their whole leg will be cold, and as you resuscitate them, the warmth will start gradually moving down the leg as their perfusion improves. So I found just touching them is almost some ways better than a formal temperature reading. But I don't know if that's evidence-based. That's just what I've discovered.
It'd be interesting, worth looking that up. But I do agree. I think in the remote provider, in the absence of, say you're the single person and you're doing this, you don't have a staff to pre-screen your patient and check all these vitals and a temperature and everything, that what you can gain by just touching your patient when you're doing the initial, visual assessment is very helpful. And that's exactly what you're describing. You can put a hand on the patient and you can kind of see, does it match what you're seeing and the rest of the history, what you've anticipated? So no, that's a good point. It'd be interesting to see if there is evidence base behind that. Awesome.
What I think is important is that, as Mason mentioned already, some of the very sick sepsis patients are also getting cold, because like the most severe sepsis patients I treated were like super cold, so that's why I like stopped to rely on temperature so much. So I just have it like as a additional indicator. But yeah, I didn't really knew this before, so that's why I think it's just also important to mention.
How much does that coordinate with the geography location where you guys are? Whether it's, you know, what's the ambient temperature in relation to this cold or hot to your patient? Is it just more of a contrast? If you're really cold, do you have a warm patient? If it's really hot outside, you kind of sense that they're cold, you know?
No, I mean, I've done most of mine at room temperature, so I think it's honestly patient dependent. And like, I mean, unless you're at a higher temperature than the patient, like unless you're in an environment that's more than 37 degrees, if you touch them, they'll feel cold or hot. I find, at least. I mean, it's not like they're going to be more than 37 because of the temperature outside, unless it's very, very hot. So if you, like I said, I found pretty specifically if they're warm to the extremities, not a good sign. But even worse if they feel very cold to the extremities and warm to the core, because then their core's got like a dilation, but their extremities are clamped down.
Yeah. No, I see that too. No, that's good. Good discussion. Anything else, Aebhric, before we go on to the next one?
Nope. I'll put us forward.
Vish, do you want to talk through that?
Yeah, so I mean, the whole feeling your patient and understanding what's going on. Like I said in the chat, I had a patient in Louisiana who was an 90-year-old lady, frail, small, and she was cold. Her extremities were really cold. Her forehead was warm, and it was summer in Louisiana, so she wasn't supposed to be cold, but she was septic. She didn't have anything else going on with her. She was also 90 and, like I said, frail, so she probably didn't have any. I would almost think about her as a child with limited ability to have compensation after a certain period, and that's the kind of patient which you can also get. So.
No, that's a good point. I was just reading an article by Bay et al. In 2025 of comparing the early warning scores for predicting outcomes, and it's talking about the elderly. And then they said that the most consistent was the QSOFA, where the news and what is this called? The Rapid Emergency Medicine Score, the REMS, is another warning system predictor for it. I can drop this article in the chat. Go ahead, Phil.
I just going to add I guess, personal point. Several years ago, post-operative, I ended up with some sepsis, and I remember the wound being quite hot, but lying in bed at home before heading back to the hospital, I remember distinctly being really, really cold. Feet and hands exceedingly cold and shivering. Just I guess a personal data point. That, yeah, I wouldn't have expected at the time.
No, I think honing our ability to match our physical exam to some vital signs that we find is a great equalizer when we don't have all the tools and people that we need. And we need to be able to recognize when we feel something or when we see something, and match that up with experience to give us consistency and confidence when we say, all right, when I put my hand on somebody and I feel an extreme temperature, high or low, it corresponds with what I'm thinking is going on. And I think that's a skill that all of us should strive for. So antibiotics, antimicrobials, the CPG does a really good job of saying you can start generic, but you want to target your goal to the most appropriate antibiotic therapy when possible. This is based off of, what they're carrying for war wound therapy. This is based for military, based on the CPG. So if you are under different protocols, you want something that you can give to cover broad spectrum, and then more specific as you get some of your lab results back. Any comments or any different medicines that people like for PO or IV based on where they're located? Go ahead, Tanga.
Can you please talk to, okay, this is a bit contentious. We just started administering pre-hospital antibiotics for our septic shock patients. And there's the inevitable, your expletives on arrival at hospital when you've informed them that you've given antibiotics prior to them drawing labs. I just talking about the fact that, evidence shows that every hour of septic shock without antibiotics has an increase of 11% mortality potential. And, there is always going to be, especially if we're in a remote setting, having that argument as to, because how, they're always the argument is, how are we going to be able to tailor those if we don't know what the thing is that we're treating because you've already killed it. But I don't know.
No, I think it also depends on how long you're going to sit on this patient too. When they wrote this sepsis, it was based off of early and rapid evacuation of theater. And so it'd be interesting to think what it changes to when you're in a prolonged environment, say, on the continent of Africa or stuck on somewhere in the Pacific, Alfredo.
I just want to, once we talk about pre-hospital antibiotics, I just want to give into my experience. In 2016, I was in Isle of Wight, so United Kingdom, just south of Southampton. It's a small island, and the guidelines that we had is we could give, in case the patient was, we have some, at the time we were using SARS, now it no longer exists, but if we see evidence that the patient was septic and we could pinpoint the origin of the infection, we could start IV antibiotics. It was penicillin and taxovan IV. However, what we were doing, we're collecting aerobic and anaerobic samples to give to the A&E department in order for them to at least have some blood before the antibiotic goes in, to see what kind of infection was aerobic or anaerobic, and give the appropriate antibiotic. However, we're also instructed that if we couldn't get a patient was too vasoconstriction, we had no blood coming out, and the patient was critical, could give antibiotics either way, because it's life of limb. So it's nice to know what kind of antibiotic we're supposed to give, but I think the patient needs the antibiotics straight away. It's better to give it. Just want to share my experience. Thank you.
No, that's good. Thanks for sharing. I agree. You want to go to malarials?
Yep.
So what anti-malarial is everyone taking? Is it Malarone where they are in the group? Anybody, if they're in those areas?
I did that last week for Tanzania.
Mm-hmm. Yeah, I felt, I say this somewhat tongue in cheek, I felt cheated. I never had Mefloquine Mondays. I never had the dreams. I never had any of those things but my guys would have them.
I'm the same boat. We had that for 7 months when we invaded Haiti in '94, and then everyone, I heard other people like, "Oh man, a vivid dream." I'm like, "Oh man, nothing." No.
Yep, we were there at the same time. Yeah. So the thing with malarials, if the treatment, the initial treatment of them, if you suspect that they've got malaria and they've been on Malarone or some other medicine, you can't do the initial. So if they were taking Malarone for prevention, then you can't use Malarone in the treatment, because the theory is that until you can prove later, or they admit that they missed more doses than they took, which is why they got malaria, you can't use the same treatment as the preventive. And so you have to switch up. So if you're the provider in those remote areas, you need to have a staggered level. Like if you know your people are on Malarone, you need to have CoROM to give as a treatment, because your gut call in the theory is that they have a resistance to Malarone, which I think there's some documented cases now, but there's not. I'm kind of getting out ahead of my skis on this. There has to be some resistance to this now, but yeah, at the time when I was taking it, a while ago. There was no documented resistance to it, but it's going to come around just because we use it. You should have a cheat sheet and be familiar with the regimen, how you're going to do it. But if they are taking something less than Malarone, you can use it to treat 4 tablets, basically by mouth daily for 3 days. And you're still doing checks. You're going to do the thick and thin smears or the rapid tests to see what's going on to confirm it. But if you're in a malaria endemic area and somebody gets really sick, it's probably malaria, right? And then you scale up to CoROM if you're doing that. And then is anybody in a location where they have access to IV artesunate? The military, the U.S. military has it in, a few locations on the continent of Africa and in some of the theaters in Middle East. I don't see anybody responding on that. So, okay. And I know they have it in Germany too, in Europe.
It's a severely controlled drug in Thailand. We were on the Burmese border ages ago, and man, it's illegal. I don't know if it's a felony or just a severe punishment if you're caught with artesunate, because they don't want to have any touch. Because it used to be over the counter, and now they're cutting down because of the fear of resistance
to it. Yeah. So if you get a patient that's got really severe cerebral malaria, we had one case out of Central Africa come through, and once they got to Germany, they were on IV artesunate. Actually, no, when they got in Italy, they were given IV artesunate because it was the only thing that was going to touch it. And he was touch and go for a while, and then he turned around. But definitely IV artesunate is controlled. So just know that you need to find a location. If somebody is still got malaria because they were taking Malarone and CoROM, that the next thing up is going to be artesunate. You need to know where that is to get your patient to it.
One thing that we learned at the London School of Hygiene and Tropical Medicine, they taught us that when you separate the severe and the non-severe malaria, it's all about swallowing, and that's it. So they basically said, can the patient swallow? Then they get CoROM, which is a tablet. If they can't swallow, they're now severe malaria, and the only option is artesunate.
Right. Cool. You want to go to the next slide? So for antifungals, pretty much what you're going to take orally is the fluconazole. If you suspect that you have a fungal source for your sepsis, it's all through the CPG. You need to call telemedicine, because chances are you're going to be giving the antifungal and other antibiotics. And so you're going to need to manage that for somebody that's got probably more training than we do, and they're not under the same stressors, so they're going to work through it. Probably consult some pharmacology and some internal medicine guys to infectious disease to kind of help you manage all of that going on. This one's a pretty straightforward. The CPG is very adamant that you consult telemedicine, but I would just say extend that to any really sick patient in a remote area and get feedback on how to manage your patient. Even if it's just to confirm what you want to do, that helps. That gives you a little bit of peace of mind. You want to go to the next? So when you're resuscitating your patient, the goal is to replace that lost plasma over the next 24 to 48 hours and maintain the perfusion. So you get those 3 plates. You're managing the 3 plates, meaning a MAP above 65, urine output of at least 50 milliliters per hour, or 0.5 to 1 cc per kilogram per hour. And then you want to make sure that your patient is mentating properly. That's your goal. So in the absence, you can have, in the absence of IVIO, or even to augment, if you have limited crystalloid supplies, you can have the patient drink if they're able to, and you can monitor urine output. Going back to what Aebhric was saying is, determining whether your patient has the ability to swallow is, it affects how you're treating the patient, right? And so if you're trying to preserve a lot of your supplies, or if you're in limited supply, having the patient consume fluids as normally as possible, you also get fewer side effects. It's harder to over resuscitate a patient if you have them consuming fluids orally. You can treat for nausea, you can treat for the other things, the concomitant stuff to help keep whatever they drink down. But then if you have the ability, then you can use IVIO to do bolus fluids. It's generally 30 cc's per kilogram to hydrate, whether you do those in micro boluses or aliquots or you just do it as a big bolus. It really depends on your location and the comorbidities going on with your patient, in addition to whatever illness has got them in sepsis. And then obviously best when you're resuscitating is to track the I's and O's, and that means through a urinary catheter. Or catch and release, if you have to catch and release. You got something, neighbor?
I see that oral rehydration is always the bare minimum in the CPGs. And I want to quote Dr. Ella Corrick, who heads our doctoral program. I was teaching some Swedish Soft with her. She got to this CPG and she stopped right in the middle of the lecture. She's like, I don't agree with this. Oral rehydration is the best option, not the minimum option. Because one, we don't have a lot of kit. Two, their body is going to replenish what they have and what they need and then pee out the rest. So I have to agree with her. So if they can swallow, they can or barely swallow, you can put an NG tube down and still do oral rehydration. So don't jump so quickly to IVIO crystalloids.
No, I remember you saying that during the burn resuscitation too, during the burn talk. So no, I totally agree. And actually I wrote a note. I literally have the sticky and I had to search for it on my desk, right? 0.3 to 0.5 milliliter per kilogram per hour urine output in sepsis. Yep. So yeah, no, I remember that. And I agree. I think even for the remote provider, having your patient consume things in the most natural way possible, meaning if they normally drink fluids, have them drink the fluids. If you can augment them or supplement them or secure it, make it as safe as possible by putting an NG tube down. If you have that ability, or an OGT, definitely. It expands your options. You can filter water and make sure that it's got electrolytes and give them that way. So no, I think keeping things as simple as possible is our greatest resource. Not overcomplicating things. No, I agree. So yeah, your goals in your resuscitation is maintaining that MAP greater than 65 and urine output greater than 50, and then make sure that your patient is mentating. Any comments on the resuscitation on this? Okay, next one. So monitoring your patient. Go ahead, Neil.
Can you hear me?
Yep.
So it was going back to the burns CPG. There was the discussion between 0.3 to 5 or 1 milliliter. Yeah, like 1 milliliter per kilogram per hour, 0.3. Where should I be starting? I guess just starting at the lower end and then like trending my vitals.
So you're going to measure whatever comes out. And I suspect, depending on what your patient's hydration status was before they got sick, is going to affect how long it takes for them to get up into the goal of urine output. You get a person that's been dehydrated, long road march, long movement, whatever, and then succumb to an illness. They're going to be more dehydrated than somebody that's at baseline. And so you're going to have to get them to normal before you can maintain the correct urine output. So I think it's going to be a scale. So you're going to, like, the first hour is probably going to be nothing to scant. And then the next, 30 to 60 minutes, you're going to start getting more urine output, which is going to be suboptimal. And then in your third hour, you might get somebody and you might get them making more urine, which you want to be careful that you don't over resuscitate, causing a complication trying to get that target urine output. So I think you need to be able to trend it over time to get it into that goal. So I think it's why they lowered it down to 0.3 to 0.5 versus 0.5 to 1. Does that make sense?
Yeah, makes perfect sense. Thank you.
Okay. No, good question. Good clarification. So when you're monitoring the patient, you just have to collect and document and trend your vital signs. And you need to do that with your mental status and your urine output. When you're doing mental status, the best way to do that, I think we mentioned this through a few previous lectures, is talk to your patient. You're going to detect changes in mental status by conversing with your patient way faster than you are by doing mini mental statuses and any other mental assessment, mental status assessment. Just having that regular communication. Do they remember your name? Do they are able to come up with details that you're asking them? Like, when was the last time you ate? When was the last time you did this? Did you take your anti-malarials? All of those questions. It's not necessarily the answer that they're giving, but how long and how much effort does it take to answer you? That's part of the mental status too. And it's really hard to document that. You're just going to get a feel of what normal seems like. And then either it's going to improve because their answer is going to be more rapid and clear, versus delayed. They're going to be searching for answers. You can see them visually trying to remember or calculate something. And so that gestalt over time is going to give you a more accurate assessment of their mental status than you documenting a number or tracking a Glasgow Coma Scale, right? And then basically adding additional labs that you're trending over time. What is their lactate? Is it trending in the right direction? More so than what the actual number is. Is it going in the right direction? And then if you're able to use some point of care ultrasound to assess the inferior vena cava to determine what their hydration status is, are they still, is the IVC still collapsing with a sniff because they're hypovolemic, or whatever, what's the left ventricular function look like? Is there good volume going through there? Is there good ejection fraction? All of these things are things that you can do if you're making assessments using a point of care ultrasound. Any comments or questions on that? Does anybody, how many people have access to point of care ultrasound devices? Okay, we got one. Good. I think
I should be getting mine in about a month's time.
Are you already trained, or do you need to get trained?
I've done a little bit of training previously, but they're supposed to be sending me to a course for it. So get practiced.
Come to Malta. We're running it next weekend.
I wish I could travel, but I'm kind of stuck here.
Fair enough.
Yeah, I think if you have access to ultrasound, you got to play with it. If somebody comes in with a sprained ankle, you're going to do a fast exam on them. It's like, just get comfortable using the device, and then try to get with somebody that's good at it, that can teach you good techniques. One of the downsides to self-directed learning is that you can develop some really horrible habits that you have to unlearn later and then relearn the correct way. So it's good to pull it out and look at things, but try to have a good mentor or somebody that can teach you good habits. That's probably one of the biggest downsides to, I'm a huge fan of point of care ultrasound, but I'm also a huge fan of the right technique and doing things more efficiently and effectively, in the opposite order. Become effective and then become efficient being effective is my technique. So I definitely like using it. It's a very helpful and useful tool. You want to go to the last monitoring? So, just as a quick cheat, when you're looking at it, your goal in your resuscitation is obviously a MAP greater than 65, good urine output, and mentation. But a good way to kind of estimate your MAP is to keep a systolic above 90 or 100, or if you have a concomitant TBI and an infection, which really bad indicator for your patient, you want your systolic blood pressure to be in the appropriate range. 90 would be considered permissive hypotension. You're going to let it stay for a little bit so you don't overcompensate or over resuscitate your patient, but you don't want to get that up there above 100, or you get your shock index where the systolic blood pressure is higher than the patient's pulse. That's another very quick surrogate for how your patient's doing. Are they trending in the right direction? Cap refill is a good tissue perfusion to the periphery is a good way, and you can check that. It says Q30 because it's in the CPG, but anytime you go talk to the patient, you can check a peripheral pulse and pinch a finger. Those are easy things to do. It's kind of a good reflex and habit to do on your patient. You can also check skin temperature responses. So, all of these things are just building good technique in any monitoring of a patient. If you incorporate those things into your general assessment, it just becomes more of a reflex than a thought process. And you'll notice findings that are abnormal. Like if you do it often enough, you'll notice, hey, this doesn't feel normal. This doesn't look right. And that instinct that you're going to form is going to be through, hundreds, if not thousands of reps. Repeat the labs. Now, obviously, this is highly contingent on supplies that you have in your iStat or your RDTs. So repeat them when they make sense. I like that they didn't put a time limit or a time reference, like Q10, Q15, Q30 hourly. You're going to really base that off of the amount of supplies and capabilities and equipment and personnel that you have where you are. But you want to see if the patient is responding to your therapy and are they responding appropriately. So repeat the labs as needed. And then if you really do need to ventilate or, do something with your patient respiratory, if they're doing really south, then, obviously do so for your patient. Any comments or questions on general monitoring? Any suggestions or tips that you guys have used in the past? Go ahead, Mason.
I noticed you guys had mentioned iStat a couple of times. I was in a course recently and someone mentioned the Epoch, and to be honest, I've never used either of them, but they said the Epoch doesn't need to be refrigerated and that it has everything in one cartridge. What are your guys' thoughts on those two devices? And, is the iStat what you actually use, or is that just kind of a tissue, like a Kleenex, for you use it as a generic name for any point of care?
No, it's a great question. The Epoch is liked by a lot of people a lot better for the reasons that you stated than the iStat. I think when they wrote this CPG in 20, or at least, I've got some edits back from 20 on this. The Epoch really wasn't that on the radar. I don't even know. It might have been out there, but it wasn't on people's radar as it is now. So it's just a general point of care lab tool. So, but thanks for bringing up the Epoch. That's if you have that available, that's good.
Yeah, we have that in the classroom. I've used both. Epoch is $8 per slide per cartridge, and doesn't need to be refrigerated. And the iStat's $40. So guess which one you're going to find in remote and austere environments? Alfredo.
Just a question about the labs. Is it a requirement to upload or update the system every 3 months? Because I used both and it was a pain to pay an extra in order to update the software. Is there any way we can go around it, or is it still mandatory?
So yeah, if I remember, it's every 6 months, and you can call the helpline if you're going to deploy. Supposedly they'll pause your mandatory updates, but I'm not holding. They're both owned by Abbott now, so I wouldn't hold my breath, brother.
All right, thank you.
And Vish put in the chat, change the date and it resets. That works? Wow. Okay. Okay, that's good.
Nice. That's people taking care of people there.
That's good. Even your point of care, like the Butterfly, depending on what subscription you have with them, if you don't get the updates, it'll stop working. You can call and let them know to have that suspended when you're going to be in remote areas, or you can pay at the beginning so you don't have the subscription. They charge you more because it's kind of like buying a new car. They're going to get you with the maintenance plan versus the car, so they want you to get the updates. But if you kind of suspect or know that you're going to be in a remote area, you can have that turned off. You got to communicate with them first.
Well, actually, with the Butterfly, though, eventually it still stops working, which is a real pain in the butt. So my friend's working to jailbreak it and rewrite a version of the app that doesn't have any updates or payments required. I'll update you guys as I hear more.
Yeah, I think at some point, it doesn't turn off when you don't have the every 30 days, the mandatory. But it's like whenever you get back to Wi-Fi, they want you to kind of update it if you can. So if there's a hack around there, that's interesting. Alfredo, you got a hand raised up. Is that from before or is it another?
I was from before, sorry.
Okay, no worries. Just want to make sure we're covering. You want to go to the next slide? So the thing I like about the CPG in this, one of the things I like is it does give the appendices where you have some standard stuff for reference if you can't get them in other locations. So instead of listing them all, you can just pull out the CPG, and the A is for the, a good patient management checklist. I think you get a lot of the same information in the PFC flowchart. It's in the column on the right side. Will give you a lot of good ideas. It'll give you some ISTAP lab values if you don't have them, but you might have a good poster printed up. Some different abnormalities detection. So your malaria rapid test, some lactate references, and then your epinephrine norepi vasopressor guides. The Appendix G is the same on every CPG that comes out of the joint trauma system. It's an additional information regarding off-label uses, which is basically kind of a disclaimer saying, some of these things are off-label. Don't hold us liable if you have bad outcomes because you're in a remote area. So that's all I have for sepsis. The next one is that sepsis CPG out of the CoROM Rapid Field Guide. You want to talk about that, Aebhric?
So yeah, this is page 148 on the second edition field guide. So third edition will be a bit different. I came up, because I'm a knuckle dragger and I'm not the smartest one in the room, I had to come up with a mnemonic checklist for me, and I used Flashed as just a way to keep a heads up on my sepsis patient. And these are the things that should be on your radar when you're dealing with sepsis. And then, yeah, the sampler assessment is just making sure you find out the R's, where have they been, the R's recent travel. So just make sure that they haven't traveled somewhere silly.
Why is hydrocodone on there?
So Bill, can you talk about the pathophysiology of hydrocortisone?
Well, it's an anti-inflammatory response. So hydrocortisone, you said hydrocodone, it's hydrocortisone.
Yep.
Was that, no, so did you ask why would there be hydrocodone on there, or did you?
Sorry, that's what I meant. I just meant steroid in general, because are we reducing the ability for our bodies to fight it?
Yeah, it's an anti-inflammatory. So instead of having a non-steroidal anti-inflammatory, this is a steroidal. So it's to reduce the body's inflammatory response.
So then aren't we reducing the immune response as well, and therefore potentially not fighting it?
Well, so yeah, that's a delicate balance when you're doing that. It's kind of like when you twist an ankle. The normal response is to flood the area with fluid to help reduce the damage and clear away. And the problem is that it over responds, and so you have this ankle that looks like a football or a soccer ball, right? And so that over response is actually inhibitory. So you want to have some kind of balance to where the body can still fight the response with the additional assistance of antibiotics and fluids and vasopressors and all those things. And you don't want the body to over respond in some cases, because a lot of times that causes complications too. Now that's incredibly simplified, but you want the body to be able to respond, but not over respond. And that hydrocortisone can reduce the inflammatory response in the lungs primarily, is where I'm looking.
Interesting. So would this be something you do Q every 2 days to get some type of balance, if not completely?
Honestly, it depends on what type of infection you have going on. If you know that it's, say, malaria, the body's not going to be able to do any kind of response. It's going to need an external antibiotic or anti-malarial to take care of that. And so you don't want the body to over-respond, causing additional complications while you attack and treat appropriately the malaria infection.
Okay, thank you.
Yeah, no, it's a good question, because it's a delicate balance. You said may reduce mortality. Vish?
Yeah, this is I just put the reference of the paper as well. So they talk about watching for hyperglycemia, hypernatremia, and neuromuscular weakness, which is also what I have also read in other studies. So as long as you're keeping a track of it, like you said, it's maintaining the therapeutic regime should be good and is preferred. There's a couple of studies which have brought out in sepsis and early use of corticosteroids in sepsis.
Good information. Alfredo.
I just want to add an example. Again, I remember since I started, always everyone was saying steroids for sepsis is bad, don't use it, it's bad. However, even now with COVID, initially you're not supposed to give it, but then they realized that dexamethasone was actually quite good for the patients when in an ICU because they have a better outcome, exactly for what you mentioned. I just want to bring out the COVID experience because again was no until actually it works.
Yeah, medicine is one of those things where you don't. It's almost like you never want to do an always or a never response. Everything should be based on what the patient in front of you is doing, and there are good trends and good predictors, but you have to make a decision. And that's part of being a provider. And there's going to be times when it is appropriate and times that you need to avoid it. And so I hate the never crowd and I hate the always crowd, depending on what it is. So yeah, no, good point. Good point. Bringing up COVID too. Any other comments or questions? So we're asking any requests for topics in the next, 1 or 2 months.
I personally would like to see the drowning CPG gone over.
You taking notes, Bill?
Yep.
All right. Doc Mason?
Not a specific topic, but just if we can get these invites out a little sooner, because I only got the invite for this one yesterday. So it'd be nice to be able to make sure I can block it free. That'd be great.
So that's my fault because I was on the flight from Tanzania and then a day of trying to find out where I was. And then yesterday I arrived in Malta and I was like, so
Okay.
I'm so sorry.
Okay,
Do
thanks.
you guys want like a week's heads up notice? Would that be better?
Yeah, I mean, a week or two even would be great for me. I don't know.
Yeah, so I'll take that one on the chin, Doc.
No, you do a lot. Thank you very much for everything you do.
And
Yeah.
Doc Mason, before you go, I just sent you a message about email about the next WMS talk, if you're still up to it.
Yeah, I should be good for it. I'll reply. I just haven't had a chance to get to emails since I got that. I just saw it and I will reply.
Cool. I saw you here, so I said, let me ask you right now.
Good deal.
Okay, thanks.
So we got another one for requesting humanitarian medicine. Any specific component of humanitarian? That's a broad, it's like saying engineering.
Yeah, no, sorry. I have no I'm particularly concerned with like ethics in humanitarian medicine. I know that's a bit outside the scope of the college, but it is kind of a consideration, but also resources obviously, and it is kind of tied into like the politics of the region and working within the medical systems of the local country. I know it's a general request, but anything you guys could come up with in the general sphere is great.
Ethics is an interesting one. I'm on the periphery of helping somebody do something with ethics, and I'll see if it's appropriate to do in this scenario. It would be interesting. I think this might be a good, appropriate venue for the topic related to the study that I'm on the periphery of. So, yeah, no, more to follow on that. I think that's a good trigger because I think that we deal with it all the time.
Thank you so much for your
Yeah,
consideration.
no, great question. Great comments. Cool.
Would it
Anything
be
else?
possible to do? Would it be possible to do? It doesn't have to be super long, but just a conversation on feeding considerations in like long-term care. Just certain pitfalls and things that we work on. And are there really? Does chicken soup really actually do anything type stuff?
Yeah, we
Nutrition.
just had a nutrition CPG drop, so it's good timing.
Okay. Cool. No, great suggestions. All right.
All right, guys, we'll see you next month.
Thank you very much, everybody.
Thanks.